I'd now like to introduce Professor Nick Goodwin, Director, Central Coast Research Institute, a joint venture between the University of Newcastle Faculty of Health and Medicine and Central Coast Local Health District. A social scientist with 25 years in health services, Nick co-founded the International Foundation for Integrated Care and in 2016 was awarded the Avidas Donna Beeden International Award for his significant contribution to the improvement in quality of healthcare and care globally. Please welcome Nick Goodwin. Thank you.
Thank you very much. Before I begin, my name's Nick, and I've been living with my family on the Central Coast for nearly 6 years now. We're a bit of an international family, so I was born in Manchester in the UK and grew up in the South. My wife is from El Salvador in Latin America, so you might have to go and find that on the map later, hidden away as it is. It's about the country the size of Wales, but with about 25 volcanoes, just to give you an idea. And I've been lucky enough through my career to work and travel around the world, sharing information about the needs of different communities in many different countries. And that shared experience has really sat with me over the years to understand that in almost every country, we have an approach to healthcare, an approach to health and well-being, which is system-driven and professionally led, and that we do not do enough to support what was behind Faye's testimony, powerful as it was, to have more consumer-driven change and community-led approaches. And there are some fantastic examples in some parts of the world, New Zealand, and often with indigenous communities like in the Nuka system in Alaska, that have turned this around so that actually the consumers, as you would say in Australia, are the owners of the system, that the governance of what happens in that system is directly accountable to the municipalities and the people who live there, and you overcome this democratic deficit in the voice and the direction in which healthcare services are made. Now, it's really very difficult to follow someone like Faye. It reminds me when I went to a conference in Ottawa. It was a conference on developing new end-of-life policy. And in fact, what they were trying to do is get some assisted dying policy passed through legislation at their Parliament House. And they went with a candlelit vigil and a walk from the conference to the Parliament House before the vote was made. Sadly for them, in their collaborative, one of their key founders of found he had a terminal cancer, and he was able to document the last 2 years of his life, that as a psychiatrist and as an end-of-life palliative care person, what it's actually like to have a lived experience and go through that. So not only did this video come up around this lived experience, colleagues then came up with a guitar and provided a song. And of course, the whole of the community and this audience, probably as it is now, is feeling the effects of a story that pulls at your conscience and that pulls at your heart. And then they said, now here comes Nick to give the keynote presentation, a social scientist from Oxford. So, so I was kind of reminded of this because the powerful testimony that you hear is a story that you hear so many different times when you talk to people in the community falling through the gaps in care and are unable to have that voice heard. And part of that background was behind the idea for ALICE. What is ALICE? So on the Central Coast, ALICE stands for All-Inclusive Care for Older People. And it began around September 2022, so some time ago now, where I was working as director of the Central Coast Research Institute for Integrated Care. That was a joint venture between our local health district and the University of Newcastle. And we were having a strategic planning day. And our chief executive of the district said, what we really need is one big, impactful translational research project that's going to leave a legacy for the Central Coast and make a difference to people's lives. And as we discussed that, we focused on the issue of older people's health and well-being, and that we needed to have a place-based initiative focused in on priority communities and neighbourhoods on the Central Coast. So not so very dissimilar to what we heard as the PHN's strategy here. So I went away and thought, well, okay, I've been given the task to do that, put a pitch together and get some money from government. So it wasn't a small task. But I brought together ideas from all of those experiences that I mentioned from around the world to think up three things. So the Alice model of care really is a combination of those three things. One thing is the philosophy of it. So when you go to the United States, there's a program called Promoting All-Inclusive Care for Older People, where if you are in receipt of Medicare and Medicaid, so in other words, you are poorer and you're sicker and you're old, you're able to voluntarily sign up to one of these PACE programs. About 300 or so now exist. And these are small community-embedded facilities around the United States. And the idea is that if you enroll within one of these, you're looked after wherever you are in the system. So whether you're at home, whether you're in a residential village, or in a nursing home, in hospital, in a primary care setting, everybody from the receptionist who opens the door when you enter in to the staff who are working within that have the responsibility to look after you wherever you are in the system. And actually the PACE program, based out of these very small community facilities with relatively low levels of staff, have done amazing things for the clients who you could imagine they would be. So a typical client in their 80s, probably with early stage dementia, probably a woman, but actually being able to improve their quality of life and also be able to make a more sustainable impact on the costs and quality of the health system. So that was one. The second key issue was something that I learned from Germany and other places in Europe, which is about how do we address people within a community? How do we mobilize the community assets so that actually we have a focus on healthy placemaking? How do we make this the perfect place for older people to live? How do we do that? And that's all about getting people involved and mobilizing the community. Connected communities sort of idea. And then the third idea from that, what were people asking for? People didn't know where to turn for information. They didn't know where to look. So the idea of the health kiosk emerged, in which people could go not only for information and advice from a trusted source on where to go, they could get access to low acuity care like nursing care or other preventative kind of care support, but also it would be kind of act as a social centre as well. So the Alice model of care came up with this triangle of an idea. A health kiosk, a connected communities approach, and then for those older people who are not doing so well, the idea of a link worker approach, a bit like social prescribing, so that actually we can support people with their health and well-being needs by connecting them to the different community assets to keep them as healthy and well as possible and to live independently. So this was all based on a case for change. We had to do our homework, so we looked into the data and we looked into the demographic trends and so on. So the first thing, obviously, is we have on the Central Coast a very aging population, something like 80,000 people on the Central Coast, so about 20% by 2031 will be age 70 or more. And what we're seeing is that demand for care is outstripping supply. So not only do we not have enough primary care services and other preventative services to keep people healthy and well in the community, the artifact of that is a significant number of older people who unnecessarily turn up into hospitals, either as emergency admissions or planned admissions. The length of stay in those hospitals are way too long. We can't support people back into the community because the community itself does not have the housing and support to enable people to support well. But at the same time, the diagram on the right, the blue bars, are the numbers of older people on the coast who are in receipt of a home care package. And the yellow bits in there are those who are waiting for a home care package. And what we did was look at the growth of that. So a threefold increase from about 4,000 or 5,000 people in 2022 to nearly 12,000, 13,000 people who would require a home care package, probably at level 4. So you're seeing a growth in demand and a significant increase in the severity of that demand. But at the same time, are we really increasing the capacity to be able to respond to that? I think it really stretches the system because we're already at capacity. And the other thing, of course, is a line there that says there's going to be no more nursing home places. We're flatlining that. We're not going to invest in it. So there's a big issue on how do we provide community support to older people in situ through these types of initiatives. So it's really quite a significant issue, particularly as we also have challenging issues in accessing GPs and other community-based services, particularly in certain parts of the community. So talking about certain parts of the community, we work with the PHN and the district and the council and others to develop a joint strategic needs assessment to understand what the issues were for older people and others across the coast. And we looked at it at a neighbourhood level. And we came up with about 60, 70 indicators to try to understand demand and supply, risk factors, prevalence of disease, social economic circumstances, income, isolation and community transports, all sorts of different things. And we used a subset of that to try to rank what would be the sorts of neighbourhoods that would be benefit from a kind of Alice approach. And what we find on the Central Coast, not surprisingly, it's the retirement communities in the north end of the peninsula. Have anyone been to the coast? Maybe not, but the entrance and Long Jetty upwards towards Gorokan, Budgie, Tukli, that sort of area. Plus there are other pockets as well, obviously, around the coast that would need support. But these were the areas where you could really see people dropping into social isolation, not getting access to the services that they need. And the flip side of that, if you go to Wyong Hospital, which is just to the west of those 4 large pins at the top, that's really coming under pressure today from the numbers of older people who are in there who work for admissions that could be avoided. And the average length of stay now for a geriatric patient at Wyong Hospital is over a month. Okay? So this is a live issue. For many of the people there, the problem is they've got nowhere to go. Right? There's no nursing home placements. There's no care home support. The housing stock that they're going back to is not fit to support them. So what are we going to do? This is a really serious issue. We also did a number of community consultations, particularly around our pilot community in Long Jetty and the entrance. And the first thing they said to me, so what's the key issues facing older people in this community? And they said they're screamingly lonely. They don't know where to turn for information and advice. They're falling through the gaps of care. They have really struggling to understand how they're going to cope. So few people are aware of the range of community services available, the complex criteria and the application process you have to go through. Lots of things are online. Try to navigate My Aged Care, trying to understand what you're eligible for, what you have to pay for, what you don't have to pay for. Not understanding what might be available locally in terms of volunteer services and everything else the community might have to fill those gaps. This big dislocation in services and a shift in the way these are can be chronic and complex care in the community better, and we can achieve an approach whereby we can support more people to live independently in their home for as long as possible, to ensure that they have better self-reported health and well-being, improved mental health and mood, reducing stress on carers, and actually this is going to be also the smart thing to do because we're able to do this sustainably and save cost to the system. This is the promise of an integrated care approach. How do we improve care experiences and outcomes at less cost? And we put a benefits case in. So my clever people at Health Economics Department at the Hunter Medical Research Institute took all of the evidence pack we brought together, all of these experiences around the world and the impact that they had, did a sensitivity analysis on all of that data, cross-referenced it with the data that we had from the PHN and also from the district, and came up with an idea that if we put this model in place and it was mature, we would be able to save, on average, around $5,000 or more per client being provided with that support. So that's quite similar to the statistics you see for the North Sydney Collaborative Care Model, if people know that one, where we're trying to do social prescribing through general practice. So I wasn't disappointed with that. It sounded about right. And then we came to the idea for the health kiosk as well. So the added benefits of being able to grow the strength and resilience of the communities by bringing people together and addressing these particular issues, the added benefits of being able to provide people with preventative healthcare advice and support through these health kiosks and so on, was also something that we costed out. And some of these, of course, are costs, but of course they're social benefit costs. So in the end, the business case is if we did this effectively, targeted at the key communities in the areas of need, you should be able to get a 4-to-1 return on your investment, as well as doing the right things by people. So at the moment, we've progressed now to a funded pilot program, again at Long Jetty in the entrance. And in that program, a key feature is a commitment to the ongoing co-design of the program with our residents, and actually also with cohorts of a range of different providers as well, trying to find these solutions of what we're going to do. And through them, a lot of what we have planned around what a health kiosk look like, or what a link worker scheme will look like, or how we want to engage has changed quite considerably, and it flexes as we go. And I think what was said earlier as well, it's likely that when we take this to other communities, it'll be different again. So what our colleagues in the north of the peninsula might want might be different to Long Jetty and the entrance, which again might be different again to places like Gosford Centre, the more of the city centre, which is also keen to develop something else, just because of the nature of the demographics, nature of transport and all of these different things. And that's fine. If we're going to mobilise community assets, the community has to own it. So we're putting in residence committees and we're trying to put in some local governance from the bottom up so that we're responsible to them for what it is that we deliver. That's the idea. So to the end of June, we're seeking to develop these co-design initial activations with our residents. We're establishing the health kiosk, still working through the design for that and the costings for that. And the idea is we would have these link workers in place, or a link worker network in place, lots of different link workers across the system. And hopefully for full ALICE implementation, or at least the rollout to different neighbourhoods in the coming years. Hopefully, sustainably, and that's why we're taking time, because I agree with the point that you can throw a lot of money. The Australian healthcare system is like throwing money at the system. It's like putting a patch on a broken Windows system. So every time we see a problem, we'll lob $2 million at it. It'll run for 3 years and then it'll go away again. We've got to get out of that cycle of funding, I think, and that happens too often. But for potential, also, what we found, the potential for the ALICE is also to be mobile. So we're also going to see, will this work for our rural communities if we used ALICE in a kind of a bus format or other times of mobile format, so we can actually take it to older people in the places where they want it. Residential villages, rural community centres. How do we do that? And there are models around the world that have done that as well. So we hope to have at least 5 neighbourhood projects fully operational by the end of 28-29. And that's it, on time. Okay.
Thanks so much, Professor Goodwin. I personally came across Nick many years ago when I was working at the ACI, and I think we're so lucky to have someone like him living in Australia, living in our state, and to see such a rigorous and robust approach to really creating true local neighbourhood models with local democracy, governance, ownership to really drive health and wellbeing according to community needs. So I think that's really exciting, and I look forward to seeing how that progresses, particularly because I do a bit of work in aged care, and personally I am a little bit nervous about some of the support at home program that will be commencing from the 1st of July. So these other alternative models are going to be really important to support people to live in their homes and communities for as long as they can.